Welcome to Shamim Institute of Medical Sciences. My name is Dr. Kamran, and now we are going to start our MRCP Premium Lecture Series. In this lecture, first of all, we will study the high-yield organ system endocrinology. Okay, this is the first lecture of our endocrinology series. First of all, we will study pituitary disorders, and we will start from a question. Okay, a 35-year-old woman who has been presented with a weight gain for the last couple of years, and she feels that the most weight has been gained on her face and abdomen. On further questioning, her periods have been irregular for some time. She was diagnosed with type 2 diabetes, and she takes approximately 15 drinks of alcohol per day. And there are the stria across the abdomen, and there is proximal muscle weakness when asking the patient to stand. Blood tests are taken, and the sodium is 143, which is in normal range, but potassium is the 2.8, which is decreased. Okay, so the team suspects that the patient's alcohol use may be the underlying cause of the presentation. Okay, and the cause, and we want to differentiate the two. Okay, we want to differentiate the two. So what is the most appropriate investigation we can do in this patient? The first option is number A, high dose dexamethasone suppression test. Option B is insulin stress test. Option C is low dose dexamethasone suppression test. Option D is MRI scan, and option E is early warning cortisol test. Okay, so here answer is insulin stress test. This is the answer. Okay, we will study what is insulin stress test. So the answer is insulin stress test. Now we will study what is insulin stress test. Actually, insulin stress test is a test used to check the hypothalamic pituitary regulation. Okay, is it normal or not? Why? First of all, we give the insulin because insulin causes hypoglycemia, and hypoglycemia is a type of stress. When we give the insulin, it produces stress. Okay, and then stress hormones will be released. Okay, so when there is a production of artificial hypoglycemia by injecting insulin, so there will be stress hormone released from the hypothalamus and pituitary gland. First of all, it will release the corticotropin releasing hormone from hypothalamus, and that corticotropin releasing hormone from the hypothalamus, okay, it will act on the anterior pituitary. Okay, it will act on the anterior pituitary. So anterior pituitary will release ACTH and the prolactin. So that ACTH and prolactin will be released from anterior pituitary. So we will measure the hormones in the blood, and we estimate what are the appropriate target hormones that are released from anterior pituitary. So in summary, it assesses either the hypothalamic anterior pituitary reserve function is present. Okay, so what is the procedure of the test? The procedure of the test is that we inject 0.1 unit of insulin per 1 kg of the body weight. Okay, let's suppose it's a 70 kg man, we will give the 7 unit of the insulin. Okay, and we measure the glucose and the cortisol before and after the 15 minutes, 30 minutes, 60 minutes, 90 minutes, and 120 minutes after the injection of the insulin. And what will happen next? We will check the levels of cortisol. Okay, in normal subjects, in normal patients, the cortisol increases greater than 8 mcg per deciliter or 498 nanomole per liter if we decrease the glucose less than 50 milligram per deciliter. So it is in the normal patients. Okay, so in summary, insulin stress test, which is also called insulin-induced hypoglycemia test, which is also called insulin tolerance test. Okay, it is used for the investigation of hypopituitarism, and we give the insulin, IV insulin, and then we check the level of different hormones like growth hormones and cortisol. Okay, when there is a normal hypothalamic pituitary function, there is a normal secretion from anterior pituitary, what will happen? Growth hormone and cortisol should rise. When we induce the stress, hypoglycemia, and then the growth hormone and cortisol should rise. This is in normal patient. Okay, so what is the other use of insulin stress test? The other use of insulin stress test is to differentiate the Cushing's from pseudo-Cushing. Okay, so in this scenario, we're coming back to our scenario we discussed initially. That is our scenario. A 35-year-old woman presented with a weight gain, and she has a weight gain on her face and abdomen. Periods are irregular. History of alcohol, 15 drinks per day, and stria across abdomen, muscle weakness, okay, and hypokalemia. Okay, so the team suspects that the cause of this is alcohol use disorder. So what is the test that can differentiate the two? Actually, the diagnosis is here is the pseudo-Cushing syndrome. The diagnosis is pseudo-Cushing syndrome. Okay, pseudo-Cushing syndrome is differentiated with Cushing syndrome via a test that is insulin stress test. Okay, so this diagnosis due to alcohol use disorder, that is pseudo-Cushing syndrome. Okay, now we will see what is pseudo-Cushing syndrome. A pseudo-Cushing syndrome is a group of physiological and non-physiological medical condition that mimics the Cushing syndrome, but it is having a hypercortisolism or hypercortisolemia. It means cortisol is high. But very important points to mention here is that this hypercortisolemia is under a physiological normal control. So it is normally controlled by the body. Okay. So what are the conditions that can cause pseudo-Cushing syndrome? These conditions are, number one is pregnancy. Okay. So what are the conditions that can cause the pseudo-Cushing syndrome? Okay. These conditions are pregnancy, number one, and there are surgical and emotional stress, severe illness, like after the post-surgical patients, they have a like critically ill patients, and intense chronic exercise. Non-physiological condition also play important role that causes pseudo-Cushing syndrome, and one of them we have discussed in our scenario, that is chronic alcoholism. Okay, this is our scenario. Okay, so we discussed that is chronic alcoholism. Also, it happens in the patient who are obese, and also it happens in metabolic syndrome, and the patients who have poor control of diabetes, and in the patient who having a major depression, malnutrition, anorexia nervosa, eating disorders. Okay, all the eating disorders can cause this pseudo-Cushing syndrome. Okay, so we know insulin stress test was the test that is differentiating the Cushing syndrome with a pseudo-Cushing syndrome. Is that clear? Okay, so when we give the insulin, it produces a stress that is hypoglycemia, and this hypoglycemia stress increases the hypothalamic pituitary hormone. Okay, that normal cortisol is increasing after we give the insulin. That is a stress response. And if we can differentiate this insulin stress test, either it is pseudo-Cushing or it is Cushing. Insulin stress response in Cushing and pseudo-Cushing syndrome. Okay, first we will see in the Cushing syndrome. Okay, and on the right side, I will tell you the changes in pseudo-Cushing syndrome. Okay, so in the Cushing syndrome, okay, we know that there is a problem in gland. Okay, what is the problem? It is primary gland problem. Okay, either it is adenoma, okay, and it is hyperplasia. That is causing the increased level of the cortisol, which is excess cortisol in Cushing syndrome. So what will happen? What will happen? That very important point. In Cushing syndrome, the stress response of insulin will be blunted. Why? Because the cortisol is already high, and that cortisol will prevent the anterior pituitary to release the ACTH. So excess cortisol in the Cushing syndrome will have decreased ACTH. So what will be happening? Insulin response will be blunted. Okay, very important point. But in pseudo-Cushing syndrome, what will happen? In pseudo-Cushing syndrome, there will be a mildly increased cortisol from the baseline. Mildly increased cortisol from the baseline. Okay, why? Because it is normal. It is a mild exaggeration of normal response. So when we produce the insulin stress in pseudo-Cushing syndrome, there will be increased cortisol from baseline. And next very differentiating important point is the diurnal variations. In Cushing syndrome, we see that there is loss of diurnal variations. Okay, we know that there are some times when cortisol is high, like in early morning. Okay, so this variations, which is diurnal variation, is maintained in pseudo-Cushing syndrome. Okay, so there is maintained diurnal variation in pseudo-Cushing syndrome, and there is the loss of diurnal variation in Cushing syndrome. Okay, so this is very important differentiating point here. So next we will discuss what are the contraindication of the insulin stress test. Okay, contraindication of the insulin stress test. Okay, we cannot use insulin stress test in epileptic patients because you know that hypoglycemia can precipitate the seizures. So in epileptic patients, we cannot induce hypoglycemia by giving the insulin. So we cannot use in epileptic. And next is ischemic heart disease. We cannot use in ischemic heart disease, and insulin stress test is not used in adrenal insufficiency patients. So these are the contraindications. Okay. So we have discussed insulin stress test. Okay. We have discussed what is the importance of insulin stress test, and we have discussed the importance of pseudo-Cushing syndrome and what are the risk factors that leads to the pseudo-Cushing syndrome. Okay, now we discuss the dynamic pituitary function test. Okay, what is dynamic pituitary function test? Dynamic pituitary function test, these are different tests. We inject some different hormones from in the body and we check the different release of hormone from the anterior pituitary. Okay, so we check the function of pituitary gland. These are dynamic pituitary function tests. Okay, which hormone are being ejected? Insulin, thyrotropin releasing hormone, okay, luteinizing hormone, releasing hormone. These are given to the patients, and then what we check? We check glucose, we check cortisol, we check growth hormone, we check thyroid stimulating hormone, we check luteinizing hormone, we check follicle stimulating hormone at different intervals, like 15 minutes, 30 minutes, okay, 90 minutes. Is that clear? So sometimes prolactin is also used. It is also measured. We will see how insulin, thyrotropin releasing hormone and luteinizing hormone releasing hormone are increasing all of the other like glucose, cortisol, and growth hormone, and etc. Why? Because we know that these hormones are the acting on the anterior pituitary. We know when we give the insulin produces hypoglycemia, stress, and that stress increases the ACTH release from anterior pituitary that causes the more release of cortisol. Like this thyrotropin releasing hormone, it is normally released from the hypothalamus when it's act on anterior pituitary, so it will cause the release of thyroid stimulating hormone. So luteinizing hormone releasing hormone, it acts on anterior pituitary and it causes the release of the LH and FSH. And also insulin, when it causes hypoglycemia, not only it releases the cortisol, but it's also the important role to release of the growth hormone. And sometimes when we give all these hormones, sometimes prolactin is also increased or released in the blood. Okay, so what are the different levels we check in the body? What is normal dynamic pituitary function test? Okay, what is the normal dynamic pituitary function test? Normally, when we give insulin, thyrotropin releasing hormone, luteinizing hormone, releasing hormone, then the growth hormone rises greater than 20 milli-unit per liter. Okay, and the cortisol rises greater than 550 millimole per liter. Okay, thyroid stimulating hormone rises greater than 2 milli-unit per liter from baseline level. And the last we check if LH and FSH, okay, they should double 2x. Okay, so and the last most important point is what is the importance of dopamine antagonist test? What is the importance of dopamine antagonist test? What is this? First of all, we should know that what is the importance of dopamine. Dopamine is neurohormone. Dopamine is neurohormone that is released from the hypothalamus. Okay. So the dopamine normally released from hypothalamus, it acts on the anterior pituitary. Okay, what will cause this? It inhibits the two hormones. Okay, it inhibits the two hormones. Which of the two hormones? One of them is prolactin, and other is TSH. Okay, so it inhibits prolactin and TSH. Normally, when dopamine is released from the hypothalamus, it acts on the anterior pituitary and it inhibits the prolactin and TSH. Okay, so when we give the antagonist of dopamine, what will happen? When we give the antagonist like the metoclopramide is the anti-emetic drug, which is used for vomiting and nausea. Okay, so what will happen? It is used to check for the hyperprolactinemia. Why? Because when we give this antagonism of this dopamine, so dopamine from the hypothalamus will be inhibited. And dopamine will be inhibited from the hypothalamus. What will happen? There will be increased release of prolactin. It will be normally, prolactin will be more released from the anterior pituitary. So normal response after the antagonist of the dopamine is given, that is the twofold rise in prolactin. Okay. So if there is prolactinoma, a tumor of the lactotroph cells, that will be a blunted response. It will be more production of prolactin. Okay. So dopamine antagonist tests are used to check either there is a normal response or either there is hyperprolactinemia. So this is also the part of the pituitary function test. Okay. So in this we discuss the pituitary function test. What are the effects of insulin, thyrotropin releasing hormone, luteinizing hormone, and releasing hormone? And we discussed what are the normal dynamic pituitary function tests that increases growth hormone, cortisol, TSH, LH, and FSH. And then in the last, we discussed dopamine antagonist. We discussed dopamine release from hypothalamus. It acts on anterior pituitary, inhibits prolactin and TSH. When we give dopamine antagonist, an antagonist like a metoclopramide, and that is used to differentiate either it is hyperprolactinemia or it is a normal response. When there is a normal, there is a twofold rise of prolactin, but when there is a prolactinoma, it will be a more than twofold rise of prolactin. So if there is a more than twofold rise of prolactin, that suggests a prolactinemia. Okay. So we're going to the next a question here. A 35-year-old woman, who was admitted to the hospital due to new onset headache associated with vomiting and changes in her vision. On examination, she has a bitemporal hemianopia. An MRI scan of the head identifies 15 millimeter solid suprasellar mass. A pituitary blood profile shows following. Prolactin level, which is 14, it is normal. FSH 15, it is normal. LHS is low. Okay, it is low. And next TSH, which is in the normal range. Okay, going to the next. Okay, and next is the free T4, that is 11.5, that is in the normal condition. It is normal also. And we give the level of growth hormone after insulin tolerance test. Here the point to be note here is growth hormone after we give the insulin. That is only 3. Normally it must be greater than 20. We discussed in the previous lecture that when we give insulin produces hypoglycemia. Hypoglycemia causes stress. So stress hormone will be released from the anterior pituitary. And these stress hormone are cortisol and as well as the growth hormone. So growth hormone after insulin must be greater than 20. Or in a minimum level, it must be greater than 5. But it is 3. So it is decreased growth hormone. Okay. Next is insulin growth factor 1. That must be between 6 and 36. But it is 4.2. So it is low. So insulin-like growth factor are low. Okay. So next, ACTH stimulation test shows the 8 a.m. cortisol, which is fine. And the cortisol 30 minutes after the stimulation, that is 695 nanomole per liter. That is also fine, normal. Okay. So the problem, what is the most likely cause of a presentation? So what is the most likely cause of this presentation? First answer is Addison disease. Next is cerebral lymphoma. Third option is craniopharyngioma. Fourth is non-functioning pituitary adenoma. And the fifth answer is prolactin. Okay. So the here answer is non-functioning pituitary adenoma. Okay. So this is a scenario of non-functioning pituitary adenoma. The correct answer is non-functioning pituitary adenoma. So we will discuss now what are pituitary adenoma. Pituitary adenoma is a benign tumor of pituitary gland, and it is 10% in all the people, and they are asymptomatic. They are mostly asymptomatic, and when they are found, they are having incidental findings. So that's why sometimes they are called incidentaloma. Okay, incidentaloma. Okay, this is incidental finding. So the question sometimes asked in the MRCP part 1, it is a very super important high yield question. Okay, high yield question in MRCP part 1, that is, which of the following is a most common pituitary adenoma? We know that there are different type of cells. That cells are the lectotrophs, okay, thyrotrophs, and different. We'll study in the next slide. So the most common type of adenoma, that is prolactinomas. Okay, prolactinomas are the most common. Prolactinomas are the most common type, and they produce excess of prolactin. Okay, so I can say, first of all, summary of pituitary adenoma, it is 10% of the people asymptomatic, and it accounts of 10% of adult brain. So remember the 10%. Remember the 10% word from pituitary adenoma. So common in 10% of all people and around 10% of adult brain tumor. Which is most common? The most common MCQs that are asked in MRCP part 1 is most common prolactinomas. Okay, it is number 1. It is number 1. So next question is, what is second number? Second number is after prolactinoma is non-secreting adenoma. Okay, this is on second number, non-secreting adenoma. And what is the third position? At a third level, what is this? At a third level, that is growth hormone secreting. Growth hormone secreting, that causes acromegaly. And the fourth most important adenoma that presenting is the ACTH secreting adenoma. ACTH secreting adenoma that presents with a Cushing syndrome. Okay, So I repeat here the most important exam question, that is, which of the following is the most common pituitary adenoma? That is prolactin. Okay, what is the second most common pituitary adenoma? Non-secreting adenoma. They are causing hypopituitarism symptoms. What is the third most common? Growth hormone secretory adenoma. That is causing acromegaly. What is the fourth? ACTH secreting adenoma. That causing Cushing syndrome. Okay. Now we're going to the next. Okay. So we will discuss shortly what are the different hormones that are released from the hypothalamus and what are the regulatory hormone and how they act on anterior pituitary. So you can see in this picture, hypothalamus is releasing, first of all, corticotropin releasing hormone. Okay, so you see in this picture, this is corticotropin releasing hormone that is released from hypothalamus, and it acts on anterior pituitary and it increases the release of ACTH, adrenocorticotropic hormone. And the next that is released from hypothalamus is gonadotropin releasing hormone. So it will release gonadotrops. Gonadotrops are LH and FSH. It is also released from anterior pituitary. And next is thyrotrop releasing hormone. Thyrotrop releasing hormone. That thyrotrop releasing hormone is released from hypothalamus. So it will act on this anterior pituitary. So it will release TSH, thyroid stimulating hormone. So these ACTH, LH, FSH, and TSH, they are basophilic cells. And the next, there are growth hormone releasing hormone that is released from hypothalamus. It acts on anterior pituitary and releases the growth hormone. Okay, this is growth hormone. That is under influence of GHRH. And next, very important, we discussed already here, is that dopamine. DA is dopamine. That dopamine is released from the hypothalamus and it acts on the anterior pituitary. So it inhibits prolactin. It inhibits prolactin. Remember it. And also this dopamine inhibits TSH. You can see here, this inhibits this TSH release also. So dopamine is inhibiting prolactin as well as TSH from anterior pituitary. Okay, so this dopamine is inhibiting this prolactin and also is inhibiting by the TSH. Okay, going to the next. What is classification of pituitary adenomas? Okay, so we classify pituitary adenoma on the basis of size, okay, and the basis of hormone that are secreted. On the basis of size, we will first differentiate what is the term MICRO macro, and next what is the term MACRO macro. Okay, the term MICRO, remember, it is small. Okay, and the term used MACRO, remember, it is big. Okay, so when there is MICRO, it will be a small and that is less than 10 millimeter in size. When MACRO, that is will be big and that is greater than 10 millimeter. So this is on the basis of size, microadenoma and macroadenoma. Okay, next is on the basis of hormone secretion. What is the classification? We divide number 1, secretory pituitary adenomas, and number 2, non-secretory pituitary adenomas. Okay, so we discussed that there is a size classification and next is hormone secretory classification. So according to the hormone secretion, we have divided pituitary adenoma into secretory and the non-secretory. In secretory, we have a further division. Why? Because there are different type of cells. We know that there are lectotrophs, somatotrophs, corticotroph, and thyrotroph. So what will happen? In secretory adenoma, which is releasing the hormone, secreting the hormone, it is 60% of the cases. Okay, and in secretory pituitary adenoma, the most common, I told you, the first of all, very important MCQs is prolactin, which is 35 to 40% of the cases. It is released from lectotroph cells. It is lectotroph adenoma. Okay, the next very important from secretory pituitary adenoma is growth hormone, which is released from somatotroph. So it is contributing 10 to 15%. And if there is excess of growth hormone, that is causing acromegaly. And the third is corticotropin releasing hormone, that is releasing ACTH and it causes Cushing disease. Okay. And the fourth is thyrotroph cells. Thyrotroph cells are the releasing TSH. It is very less common. It is only 5%. Okay. Next very important point to mention here is non-secretory pituitary adenoma. Non-secretory pituitary adenoma. Why it is very important? Because of the nature of chromophobe cells. Okay, what is chromophobe? Because these non-secretory adenomas are origin from chromophobe cells. Why? What is chromophobe? The chromophobe is a term that is used. I can say it is not acidophilic, and not basophilic. So, it is not acidophilic cells and not the basophilic cells. We have discussed in previous diagram that some are the acidophilics in pituitary and some are the basophilic. And the cells that are not having a feature of acidophilic and basophilics, they are called chromophobe cells. And these cells, when adenoma is making from the chromophobe cells, they have a very important finding and characteristics that can come in MRCP part 1 exam question. It is a part 1 repeated question. That is, it has a high recurrence rate, high invasion rate, and hemorrhagic infarction. That is super high yield exam question. Super high yield exam question. What is a super high yield question? That is a chromophobe, which is non-secretory pituitary adenoma, that is having a 30 to 35% of the percentage from pituitary adenoma, and they have high recurrence rate, high invasion rate, and hemorrhagic infarction. These are very important points. Okay, next. We will discuss what are the features of pituitary adenoma. Okay. Features are depending upon the tumor size and the hormone that are secreted. We have classified pituitary adenoma on the basis of size. On the basis of size, we have divided either it is microadenoma or macroadenoma. Less than 10 millimeter is micro, greater than 10 is macro. And next, we have classified on the basis of secretion and non-secretion. Either it will be secretory and it will be either secretory or non-secretory. So on the basis of these size and the production of hormone, we will divide the different features. Okay. First of all, number 1 is secretory, secretion plus MI microadenoma. It means small adenoma plus secretion. So, okay. So what will be this? Because it is secretory, so there will be a symptom of releasing of excess hormone. So the symptoms will be hyperpituitarism. But because it is a small tumor, so there will be no mass effect. So there will be no mass effect. Remember this. Small tumor microadenomas don't cause any mass effect. We will study what are mass effects. So hyperpituitarism is only symptom in secretory microadenomas. What is the next? The next is secretory plus macroadenoma. It is big, large. So it is a big tumor. It is greater than 10 millimeter. So it will cause, it is secretory. So secretory, it will of course produces the hyperpituitarism sign, and it is macro, it is a big, so it will having a mass effects also. And mass effects will be compression of optic chiasma, compression of the optic chiasma, and some venous sinuses or meningeal layers. So irritation of meningeal layers or venous sinuses, that causes headache. Compression of optic chiasma, that leading to bitemporal hemianopia, and compression of some eye nerves, that will causing diplopia. We will study next what is the structure and what are the associated anatomy of these and why it is causing mass effects. Okay. But the next very important is the third point, that is non-secretory, and microadenoma. You saw that it is non-secretory, so there will be no symptom. And there is microadenoma because it will always never ever has mass effect. So it is asymptomatic. It is very easy, no problem, non-secretory microadenoma. And the fourth important point is here, that is non-secretory, but it is having a big size, macro. So it will be symptoms, it is non-secretory, so symptom will be hypopituitarism, decreased hormone level. And still it has a mass effect because it is macroadenoma. So same mass effects like headache, bitemporal hemianopia, and diplopia. Okay, so we have studied, okay, what is the summary? Summary is that, okay, when there is macroadenoma, and there is macro, macro, it is having a greater than 10 millimeter and greater than 10 millimeter causes the mass effects, Okay, so next we will study what is mass effect. What is mass effect? We will study here. So mass effects is two types. Either this tumor can extend in the superior direction, either it can extend in lateral direction. Okay, so either it will go superior direction and it will go into the lateral extension. First, it will go to superior. So if you see the anatomy, the mass effects. First, I will show the anatomy. What is the anatomy? Okay. So you can see in this picture. This is the pituitary gland here. Okay, and you can see this is superior. This superior, it is optic chiasma. Okay, I am mentioning with blue color. This is the optic chiasma. Okay, this is optic chiasma. Okay, this is optic chiasma. So this is superior to the pituitary gland. So this is pituitary gland, and superior to pituitary gland is optic chiasma. What is lateral structure to this pituitary gland? What is lateral structure? So you can see in the diagram, the lateral structure in this is this is lateral structure. This is lateral. So lateral to this pituitary gland is the nerves and cavernous sinus. You can see this is cavernous sinus, and these are the nerves, which are cranial nerve 3, 4, okay, parts of 5 and 6. These are cranial nerves and cavernous sinus. These are the lateral structure. So we discussed that the anatomy of the pituitary gland. Superior, there is optic chiasma, and the lateral, there is the nerves and cavernous sinus. Okay. On the basis of anatomy, now we will study the mass effects. Why we will study the mass effects? Okay. So you can see if it will go the superior extension, it will compress the optic apparatus, and it later can compress the hypothalamus. When it's compress the optic apparatus, that is optic chiasma, so it will cause the symptom which is bitemporal hemianopia. Bitemporal hemianopia. Okay. Next, what will be causing when it extends the laterally? What will be causing in lateral? Because it is lateral, there is cavernous sinus, and there are third, fourth, and sixth nerve. So it will compress these nerves and cavernous sinus. So it will causing symptoms of diplopia in 15% of the tumor patients. Okay. So we have discussed the mass effects, and next we will discuss the what are the pituitary adenoma symptoms, how a patient can present. Okay. So it presents excess of hormone because of hyperpituitarism. To discuss if there is a secretory pituitary adenoma, it will present excess of hormone. So first of all, presentation when there is the excess of hormone in the secretory tumors. And there are secretory tumor, they will secrete. What will be secreted depending upon which hormone is being secreted. If there is ACTH excess, that is Cushing disease or Cushing syndrome. If growth hormone is excess, so it will lead to the acromegaly. If there is prolactin is excess, it will cause amenorrhea and lactate. And next important point is the what is depletion of hormone. Second important what is it is non-secretory. Non-secretory. Okay. So it will be non-secretory. So it will be presenting with generalized hypopituitarism sign in decreased growth hormone, decreased ACTH, decreased cortisol. So this will be the decreased hypopituitarism signs. And the third, the most important, that is stretching of dura. Okay, dura matter will be stretched. That causes the headache. Very important point. The symptom of headache in pituitary adenoma is due to stretching of dura matter. The third important symptom. And the fourth we have discussed is that is compression of optic chiasma that causes bitemporal hemianopia. What is bitemporal hemianopia? We will study detail in our other section, but I can give you a simple overview what is bitemporal hemianopia. Okay. If I can make a diagram here, okay, this is the right eye, and this is the left eye. Okay, so there are the different tracks that are coming. I will make this red from this side. I will make this black from this nasal side. Okay. Okay. This is nasal side is black. This is the nasal side is the black, and the temporal side is the red. Okay. So you can see that in this diagram that only the nasal fibers that are coming, which is denoted by the black color, these are the nasal fibers that are crossing. Okay, that's the place where the nasal fibers that is carrying the information from the eye in the optic tract, optic nerve. So this is optic nerve. Okay, optic nerve. So these nasal fibers that are coming, they are crossing between one another, and that crossing is called optic chiasma. Optic chiasma. So the structure and the mass effects of pituitary adenoma that is compressing at this level. Okay, they are compressing at this level. When they compress at this level, what will be the black, which is denoted by this nasal? It is N for nasal, and red, which is denoted by the temporal side. Okay, T for temporal side. This is nasal side. Here is I can make a diagram of the nose here. This is a nose. Okay, this is nasal side, and this is temporal side. Okay, and remember, very most important concept here is that nasal fiber control opposite via visual field. Very super important high yield point is that nasal fiber, which are denoted by black, these nasal fiber. Okay, nasal fiber control the opposite visual field. Okay, so the fiber and visual field is different. It means when we see from these nasal fibers, when the signals are carried by these nasal side, they are actually controlling the opposite side. What will be the opposite side? This will be this side. Mean the patient will be seeing this temporal side of visual field. Visual field is like this. This is temporal side of visual field, and this is the nasal side of visual field. This is N. Okay, so this black, which is nasal fiber, this will be controlling this temporal side of visual field. This is visual field. Okay, so that's why when there is there is a problem, compression, which is denoted by this yellow, that the problem in optic chiasma, there is compression here. What will be? The both nasal will be problem, nasal fiber. Here will be a problem and here will be a problem. So what will be happening? The field that is abnormal will be temporal, bilaterally. There will be a field that is having a problem, that will be bilateral temporal problem. So I can make a diagram. This is nasal field and that is temporal field. Okay, that is nasal field and that is the temporal field. T for temporal. So what will happen? I have shown with black. So this nasal will cover the opposite visual field, which is temporal, and this nasal will cover the opposite field, that is temporal. So that's why it is called, when the problem of optic chiasma compression happens, that is called bitemporal hemianopia. This is bitemporal hemianopia. This is why called bi mean two. Though both sides of temporal area is affected. That is called bitemporal hemianopia. We will study in more detail when we will study in the next lecture. Okay, I will show you all the different pathologies associated with your field defects. Okay, next very important is investigations. Okay, how we can investigate pituitary adenoma? Of course, we will check the blood hormone levels in the body. Okay, what will be the diagnostic modality? That is, we will check the blood profile, either what is the normal of growth hormone. If it is raised, we can compare with normal, and we will check the prolactin, ACTH, FSH, LH, and thyroid function test, like T3, T4, and TSH. We will check, and we can detect either it is hypopituitarism or hypopituitarism. Okay, we can also have the testing, that is dual field testing, and we can do MRI. Okay, MRI is recommended when there is a mass effect. Of course, we can suspect if mass effect is present, we do MRI. Okay, next is differential diagnosis. What is the differential diagnosis of the pituitary adenoma? Pituitary hyperplasia was one of the most important differential diagnosis. Okay, and craniopharyngioma, it is associated with the Rathke pouch. We will study what it is associated with Rathke pouch. It is also very important MCQs that is asked in MRCP. We will study in a separate lecture what is craniopharyngioma, the tumor of Rathke pouch. Next is meningioma. Oma is a mass. These are all tumor of the brain. We will study meningioma, glioblastoma. There are different tumors. And next differential is brain metastasis and lymphoma, hypophysitis. Most common is the lymphocytic hypophysitis. Lymphocytic hypophysitis. We will study also in the next lectures what is this problem. Okay, involvement of lymphocytes like autoimmunity and different differential. We will study more. And there is a vascular malformation also in a differential diagnosis due to aneurysm formation. Okay, so next very important topic is treatment. Next very important topic is treatment. What is the treatment? Okay, so the whenever there is, I told you, the size and the hormone secretion determines treatment. Size and hormone secretions determines treatment. Size and hormone, very important. First of all, what is incidentalomas? I told you, when sometimes we see there is pituitary adenoma but no symptoms. Okay, we just find, okay, that is not there is no management in the incidentalomas. Okay, they are microadenomas and non-secretory. Non-secretory and micro, degrees less than 10 millimeter in the size, and they are non-secretory. No treatment needed. Treatment needed only a very specific type of the tumors. One of them we will discuss the more detail in the specific cancers, while like the prolactinoma we will study in our next lecture. Okay, first we will study in a short summary what is treatment of prolactinoma. The prolactinomas will check the prolactin level. If the prolactin level is greater than 6,000 unit per milliliter, then we start the treatment. Remember, prolactinoma and all the other pituitary tumor have a different first line and second line management. Okay, when we talk about the prolactinoma, the first line is medication and the second is the surgery. Remember it. When we talk about prolactinoma, the first line drug is the medication. First we do the trial of medication, and the second line is the surgery. Okay, second line in surgery. But very important, in other tumors, it is reverse. First is surgery, and then in the second we give the medication and plus the irradiation. Okay, so remember it. In prolactinoma, the first we will give the trial of medication. Why? The most important exams question of MRCP that comes is the why? Because in prolactinomas, first of all, we give the medication to shrink the size, and then we do the surgery. Okay, prolactinoma is very important because they can have response with the medication. What are medication? We know that prolactin is released from anterior pituitary, so we will give dopamine agonist. I told you dopamine inhibit prolactin. So dopamine agonists are cabergoline and bromocriptine. Okay, we will study next. Okay, so this is bromocriptine. What is the role? Role is that they shrink the pituitary adenoma. And the second line is transsphenoidal hypophysectomy, followed by the adjuvant radiotherapy. Very important point here. First, we will give the bromocriptine or cabergoline. These are antagonists of dopamine. And then when we shrink the sum of the size of pituitary adenoma in prolactinoma, then we will do the surgery. The surgery is transsphenoidal hypophyseectomy. Okay. In other tumor, I discussed in other tumor, the first line is the surgery. First line is the surgery, which is transsphenoidal hypophyseectomy. And the second line, that is medications, followed by the pituitary irradiation. Okay. So this is a super high yield important question regarding the prolactinoma. In detail, we will study the prolactinoma in a separate chapter, in a separate series of lectures. Okay. So today was our discussion about the whole, like what is insulin stress test. Today we discussed what is the most important concept, that is pseudo-Cushing syndrome. What is the differentiating points between the Cushing syndrome and pseudo-Cushing syndrome. Then we studied the risk factor of pseudo-Cushing syndrome, and then we studied the what are the pituitary function tests, what are the dynamic pituitary function tests, and then we studied the what is the pituitary adenomas, what are the different types, and what is the classification on the basis of size and the basis of hormone secretion. And then we have discussed the features of the pituitary adenoma, and we have discussed the mass effects, and we have discussed what are the lateral extension and spheral extension due to the mass effects, and we have discussed the treatment modalities for pituitary adenoma, and last but not the least, we have discussed what is the first line medication in prolactinoma, and what is the second line. Okay, so this is the our first lecture of MRCP Premium Lecture Series. Okay, thank you so much.